we have a few more people have since signed on. So welcome everyone. Welcome to our monthly meeting. Thank you all for taking the time out to join us today. We are this month discussing colorectal and colon cancer. But before we get things started, I would just like to ask our director, Chanel Smith-Bethel, to open us up in prayer, please.
Good night, everyone. Heavenly Father, we just thank you for the blessing of life. We thank you for the blessing of health. We thank you for the opportunity to come together as a team to thank you for the blessing of Cancer Society and what that blessing is to everyone. We ask that you continue to support and strengthen all of the members of the Cancer Society, all of its supporters, all of its benefactors and donors, Father God, for the good of the purpose that we strive for. We ask that the education that we aim to put forward into the community to continue in those strides would move from strength to strength. And we ask that you guide our meeting this evening, that we achieve those things that we have set out to achieve in our agenda tonight, Father God. We also thank you for this month's focus of colorectal cancer, and we ask that you be with all those who are in the media this month, educating and drumming up support for the Cancer Society and all those that we aim to help. In Jesus' name we pray, amen.
Amen. And thank you, Chanel. I know that was kind of off the cuff and last minute, but thank you very much. I appreciate it. Welcome once again to everyone. I know that this is Holy Week and I think there are a lot of church activities going on. So we really appreciate those of you who were able to join us. We hope that some more will join as the night progresses. We do have a very great speaker and presentation for you tonight, but just before we get into that, just a few announcements. Upcoming events in April. Just a reminder that on Thursday, we are having the support group is now back to in-person meetings every second and fourth Thursday of the month from 5:30 to 7 at the Cancer Caring Center building. There will be a meeting this Thursday, and we hope that all of you who wish to join in will come into that meeting. Friday is Good Friday, a holiday, and Monday is Easter Monday. So we have a nice long weekend coming up. Hope everybody gets lots of rest and enjoy the peaceful Easter season. Also coming up in April, we will be resuming our free pap smear and PS and Lower Bogue communities. So we're excited to be bringing this service back on stream because, as you know, during COVID, we were not able to do any of those clinics. And I think there was a great need for it. So we'll be very happy to get back into that. And we will be scheduling the other islands throughout the course of the year. And we'll have more news on where we're headed next after that. Next month, as you all know, is Cancer Awareness Month, which is a big month for us. Usually lots of activities. We like to be out in the public eye to get recognition and just to kind of keep the community aware of what's happening in the world of cancer. On the 1st of the month, which is a Sunday, we will have our annual church service where we will be attending Gospel Light Baptist Church, Gospel Light Way in Cowpen Road. I don't have the details on that in terms of the time of the service, but keep checking our website and we will be sending out flyers. We'd encourage anyone who wishes to join us to come out and celebrate with us at that church service at that time. On the 28th of the month, which is the climax or the ending of the month, we'll be having the 20th Annual Cancer Society Ball, which promises to be a very exciting event. It's at the Atlantis Hotel Resort, Paradise Island. Tickets are on sale at the moment, and they can be made either at the Cancer Caring Center or through the website. It is $250 to attend the in-person, and there's also a virtual component, and that cost is at $175. and more information is available on that. One more announcement. We had a meeting last week where we were partnering with the Bahamas Dragon Boat Committee for the Dragon Boat Racing Festival, which is coming up in August. This is a new sport to the Bahamas, and it's being introduced through the Bahamas Chinese Federation, I think it is called. Yes, and so we are partnering somewhat with that group in bringing that event, because there is they are appealing for a team of paddlers to participate in the event. They're looking for cancer survivors, and in particularly, but not specifically, breast cancer survivors, because it has been proven that this is quite therapeutic to those survivors. And so globally and worldwide, more and more people have been participating. Breast cancer survivors have been participating in that sport. So there are a team comprises 14 people. So we're trying to get people to sign up for the event to participate. They will provide training and all the gear and whatever you need to get it done. So, hey, why not try something new? And you don't have to be a survivor. They are looking for other persons to participate as well. There will be a festival in August. I think the venue is being proposed to be out there by Goodman's Bay. Is one of the popular sites that they're thinking of. So there will be more information to come on that. But if you want information, you can go to their website, which is www.bcdragonboat.com. And you can even register online, and they'd like you to like them on Facebook and on Instagram. So go and check it out. It's quite interesting. I think they may have some videos to show you how it works and more information, certainly. So check it out, tell a friend, bring a friend, and let's see how many people we can get out there to participate in that event. If Dr. Shea is here, I don't know if I left out anything on that. If you want to add, Dr. Shea.
No, I think you said it all. It's still a lot in the planning stage, but you'll hear more as we get more information and closer to the dates. But you're right, we're gonna have training sessions starting next month probably. But we're gonna have more information as we get it.
Okay. So keep checking their website, and we will probably have some information up limited as well on our website, but feel free to check it out. Okay, so I guess now we'll move on to our speaker if he's ready. And our speaker this evening is Dr. Eugene Marcus Cooper, who is a gastroenterologist and internist who received his tertiary education at the University of Albany, where he got a Bachelor of Science degree in biology in 1992, an MBBS from the University of the West Indies, St. Augustine, Trinidad and Tobago in 1998, and subsequently a Master in Health Administration from Florida International University in Miami, Florida in 2005. Dr. Cooper began his clinical training as an intern at the Princess Margaret Hospital in Nassau in 1998 to 2000, and went on to specialize in internal medicine and gastroenterology at the University of Miami Jackson Health System in Miami, Florida, where he completed his training in 2009. Dr. Cooper was previously a clinical instructor in the Division of Hematology and Oncology at the University of Miami Hospital and Clinics, Sylvester Comprehensive Cancer Center from 2003 to 2006. And he is currently a consultant in the Department of Medicine at Princess Margaret Hospital and Doctors Hospital here in Nassau. Dr. Cooper has served on numerous boards and councils, including the Health Facilities Board, Pharmacy Council, and the Board of the National Health Insurance Authority. He is the immediate past president of the Medical Association of the Bahamas and is currently the medical director for the National Health Insurance Authority. In his professional experience, Dr. Cooper is the CEO and Medical Director of GastroCare Bahamas and the Outpatient Endoscopy Center. Dr. Cooper has published in several peer-reviewed journals and is actively involved in clinical research in colon cancer and H. pylori infection. He performed the first live colonoscopy in the Bahamas on that television program, Bahamas at Sunrise, in 2015, and continues to be a strong advocate for national colon cancer screening. Dr. Cooper is a member of the American Gastroenterology Association, the American Association of Gastrointestinal Endoscopy, and is the current secretary of the Association of West Indian Gastroenterologists. He has been honored by the Delta Epsilon Iota Honor Society, Phi Kappa Phi Honor Society, and is a fellow of the American College of Gastroenterology. He's married to Kathleen Cooper and has 2 children, Mia, is it Mia, Dr. Cooper? And Akeem, or is Akeem?
Yeah, Mia and Akim.
Mia and Akim. So welcome, Dr. Cooper, and I'll turn it over to you now.
Thank you. That was lengthy, but thank you very much. And I'd like to congratulate you all, the Cancer Society, on the tremendous, consistent work that you're doing. And it's a pleasure for me to give a talk on something that I talk a lot about and I'm a strong advocate for, which is colon cancer awareness and screening and prevention. So I'm going to share my screen here. Can you see my screen?
Yes.
Okay. So as a gastroenterologist, one of the things that I do most is colonoscopies. And a lot of the colonoscopies we do is for colon cancer prevention and colon cancer detection. Colon cancer is the 3rd most common cancer that we see in the Bahamas after breast and prostate. And the incidence is increasing every year. And I'll explain some of that in the next few slides. So today I'm just going to talk a little bit about colon cancer awareness, colon cancer screening, and colon cancer prevention. So just to kind of go over the jargon, you may hear colorectal cancer, you may just hear colon cancer. Both of those are the same thing, they're synonymous. The colon consists of 4 parts, different parts of the right, middle, and left colon, and then the rectum, which is the very end. The majority of the cancers that we see are in the colon, but we do have a fair amount of rectal cancers that we identify on an annual basis as well. In the United States, we have a really heavy burden of colon cancer. And this is a slide that was taken from just 2007. Most importantly, of the 142,000 people who were diagnosed, about a 1/3 of them died from colon cancer. So this tells us that when we do identify people, even in the US, where all of the latest technology is available, quite a few of them do not survive their illness. And ironically, colon cancer is probably one of the only cancers that is completely avoidable through screening. Prostate cancer and breast cancer, by the time you can see it, it's usually, pretty significant. It may have spread, but colon cancer, we can usually detect before it becomes, at a stage where it's not yet cancer. And if we remove it, we can avoid colon cancer altogether. So this is some data, local data. And I've been trying to compile local data since I've been home, which has been since 2009. And you can see up until this point, and this is only from the public system. So these were patients who were diagnosed and treated in the public system. And we had, about 50 or 60 colon cancers that were identified annually prior to 2010. This is a more recent slide, and you can see that colon cancer, which is your second row, is starting to increase. And in 2018, this is actually an underestimate, because I found out that this particular slide, I don't think included the numbers from Grand Bahama. So we do know that we're approaching close to 130, 140 cases of colon cancer a year, when you also include those cases that are diagnosed in the private sector, both at Doctors Hospital and in the outpatient endoscopy centers throughout the country. What's also interesting about this slide is breast cancer. So many of you may or may not know, we do have a high rate of breast cancer, but we have the 5th highest rate on the planet per capita, which is still astonishing to me. There's not many things that the Bahamas can say it's in the top 5 in the world in, and we are in the top 5 for breast cancer. And so I know you guys are doing lots of work with breast cancer awareness and breast cancer screening, and this is absolutely, absolutely necessary. So this kind of shows, this is local data as well, where we tend to find these colon cancers. And this is important because of how colon cancer presents. So the ascending colon would be the right side, the transverse colon would be the middle, and the descending colon would be the left. People who develop cancers on the right side, the ascending colon, which is 32%, usually present very late. So on the right side of the colon, the stools are still relatively in liquid form. And so it's not until very, very late in the course of the disease that people start to have symptoms. Because the stool is liquid, it doesn't cause a narrowing of the colon caused by cancer, does not cause a blockage, it does not cause abdominal pain, it does not cause a change in your bowel habits. It's a very subtle growth, and we usually detect these type of cancers when patients become anemic, when the blood counts or the hemoglobin is low. And by that time, there's usually pretty extensive spread, not only in the colon, but adjacent structures, particularly the liver. And this is, as you can see, is about 1/3 of the cases in our local setting are these right-sided colon cancers, which we probably and most often detect very late. And this definitely accounts for why so many of our cancers are stage 3 or stage 4, and persons tend not to do so well. So what are some of the risk factors for developing colon cancer? Low fiber diet, which I'll talk about in the prevention strategies. Obesity, which is probably 75% of our population, depending on what statistics you use. Inflammatory bowel disease, many of you have heard about Crohn's disease and ulcerative colon common compared to other countries in the region. But smoking is definitely a risk factor. And then even more importantly, I think, is family history. And this is a real challenge for us, I think, in the Bahamas, but the Caribbean in general, where we don't always know our family's medical history. We all know how difficult it is to try and do a family tree in the Bahamas because you have so many branches and lines and outside and inside and these kind of things. So sometimes, very often, family members don't know their family history. And we do know that there is a strong correlation of family history and risk of getting colon cancer. And I'll talk about this as well in just a few slides. So what are the early symptoms of colon cancer? And I always put this slide here, and I ask people in the audience to tell me what these top 3, 6, 8, what the top 8 signs or symptoms of colon cancer are. And because even though this is a Zoom virtual meeting, we can still be interactive. If anybody wants to chime in, what do they think are the earliest symptoms of colon cancer?
Change in bowel movement.
Sure. Anybody else? Actually, no.
Loss
Let's
of
see.
weight,
No, incorrect.
Abdominal pain,
No, incorrect. Anybody else feels brave? So I can shoot it down? No?
Bleeding.
Bleeding, no, incorrect.
appetite,
constipation,
Say again?
constipation,
No, and it's likely the time, if you are at risk for colon cancer, that you will have colon cancer when there are absolutely no symptoms whatsoever. So this is what your colon looks like on the inside. So a very normal, healthy looking colon on the left side of your screen, where it's sort of glistening and you can see the blood colon cancer and why our colon cancer guidelines are as such. So very rarely do we see people who are diagnosed before the age of 30. Many of you may be familiar with Andrea Darville, who just recently passed from colon cancer. She was after she was diagnosed, I mean, she was a real champion and advocate for colon cancer screening. She was very active. She was doing something every year, reaching out, getting people involved. And I just now I had to fill out some paperwork for her. And I went back and I looked at her original colonoscopy, which was performed only 2 years ago. And she had a stage 3 cancer at the age of 30. This is really unusual, and she had, and like I mentioned before, her signs were blood in the stool, and she had attributed it to something else. And she kind of waited for a few months before she got it checked out, because at that age, who would be thinking that it's colon cancer? But we see it. And very often when we see colon cancer at that age, there is a genetic component. Somebody else in the family, it may not be a first degree relative, maybe a second degree relative, more than likely had been diagnosed with colon cancer at a relatively young age. So the colon cancer screening guidelines as to when we start screening would not have even detected someone like Andrea. Colonoscopies are now being recommended at the age of 45 or 50, and she was well below that age. But when you do have a family, a first degree relative or second degree relatives that have been diagnosed with colon cancer, then sometimes we will identify these people who are diagnosed very, very early. But for the most part, you can see, 40s and 50s and 60s. This is where we tend to see, and even 70s, where we tend to see the diagnosis sort of exploding. And by getting that routine colon cancer screening in your 40s, between the ages of 40 to 49, you should be detecting and picking up these cancers pretty early. So we are, internationally, the guidelines recommend that we start some form of colon cancer screening at age 50. For people of African descent, so in the US literature, they say African Americans, but pretty much people of African descent tend to have colon cancer that's more aggressive and tend to have cancers that start to grow earlier. And so most of these societies and organizations are now recommending that people of African descent start their colon cancer screening at the age of 45. If you're average risk. If you have a family history, then even earlier. So this slide goes into what we call high risk. FDR means first degree relative. So anybody who has a first degree relative who had colon cancer diagnosed before the age of 60, we want to start screening them at 40 with a colonoscopy. If it was a first degree relative who was over the age of 60, we still want to start screening them at 40. It doesn't necessarily have to be a colonoscopy. There are other methods of colon cancer screening. And then we do that every 10 years as opposed to every 5 for the first degree relative under 60. Second degree relatives, if it's just one, there doesn't seem to be any increased risk. If you have, you know, an aunt, or if you have an uncle or a Grammy, doesn't appear to be any significant risk. We can start to screen them at 45 or 50. But if you have more than one second degree relative, then we want to drop it to 40 again, and we're doing colonoscopies every 5. The very last line talks about for persons who've already been diagnosed with colon cancer, like how often should they be having their colonoscopies afterwards. After this, if they have surgery, after the surgery, you do it in the first year, and then in 3 years, and then in 5 years, and then we do it every 5 years. So I mentioned other forms of colon cancer screening. So the colonoscopy is the gold standard. I'll talk a little bit about that because we're able to do so much during a colonoscopy, but there are other forms. So, you know, some people may say, well, I don't want to do a colonoscopy right now, and that's fine. We know that everybody can't do a colonoscopy. There is some expense associated with it. And we don't recommend that everybody, just because they turn 40, gets a colonoscopy. We don't have the amount of resources to do colonoscopies on every Bahamian citizen and resident after the age of 45. So there are other options. There's a stool test, there's a barium enema, this is virtual colonoscopy that you guys may be familiar with. And then there's the regular colonoscopy, which is the gold standard. So just going to talk briefly about these other options. This is your fecal occult blood test. So when you go to a clinic, the public clinics, this is what you're getting, and even some of the private offices as well. So our national, part of my job as being the medical director at NHI, we are coming up with our national screening guidelines, and NHI will be covering the cost of colon cancer screening once it's approved. And so this is kind of what we're doing on a national level. People are getting 3 of these cards. They're being given instructions on how to put the stool on the cards. There are some dietary restrictions because these cards sometimes give false positive results and false negatives. So there's some things that you should ask the patient to refrain from before doing the test. You know, a lot of people don't like it. It's messy. You have to kind of smear poop on the card. People are not into that. And so we're kind of moving into a more first world method of doing this. And this would be the fecal immunochemical test. It's called the FIT test. And this is what NHI hopes to bring as the standard of colon cancer screening, national colon cancer screening. So it's a lot more accurate. It only requires 1 test as opposed to the other card. You don't have to do it every year. This one you do every other year. There are no dietary restrictions, so you're less likely to get a false positive or false negative. And it's more accurate. It's a more accurate test. So this is what NHI is going to be covering in the public system and all the clinics, et cetera. Once we get the word out and once this has been approved, then we're going to be really asking the primary care physicians to get your patients screened, these average risk patients with no family history. Get these tests done every other year. And once you have a positive test, if it comes back positive for blood, then you go on and be referred for a colonoscopy. Barium enema is like an x-ray. This is a pretty good test, and we still do it. Unfortunately, you know, barium enemas seem to be falling out of favor. Princess Margaret Hospital, the machine doesn't work. At the RAN, the machine doesn't work. At Doctor's Hospital now, they don't have any reagent, the stuff you have to drink or put in. So it's not so readily available, but it does work well for screening purposes. And when it is available, it works fine. It's an x-ray. There's still some preparation involved, but for somebody who is reluctant to undergo that procedure where they have to be sedated, this is still an option. This is what a virtual colonoscopy looks like. So you will see that some people will have had a virtual colonoscopy. This does not require any sedation. This is a regular CAT scan. And they use some special software to kind of get a look on the inside of the colon. And so you get these digital images that resemble polyps, and you're able to give a report saying, well, there's something in the colon that resembles a polyp. The only problem is that if once that test is done, if there's something that appears to be wrong, then you have to go ahead and do a regular colonoscopy. So in the case of a polyp being found and it has to be removed, you sort of have to do this thing twice, which patients don't like. And surprisingly, this is a very uncomfortable procedure. So anybody who's had one done will tell you that they put this tube in your rectum and they inflate it with air, and it's cramping and it's uncomfortable and they don't like it. My mother did this test and she was very angry that I referred her for it. But there is a place for it. Sometimes when patients have heart disease or lung disease and we can't sedate them, or they're on blood thinners, this is an appropriate test to do, particularly if you're not sure if there's going to be anything. So we still do use it in some settings. So the regular colonoscopy, which is what we're advocating as the gold standard, if you can afford it, if it can be done. It does require some sedation in most cases. There are some people who are able to tolerate this without sedation. You still get the cramping because we use air to keep the bowels open. Under normal circumstances, when we do use sedation, this is painless. We can remove polyps if we see it. And if you have a normal colonoscopy, you don't have to repeat any sort of colon cancer screening for another 7 to 10 years. A virtual colonoscopy only lasts about 5 years. And the other forms of colon cancer screening have to be done more frequently. So I'm just gonna, I kind of wanted to show you guys what a really good colonoscopy looks like. I don't know if anybody's interested, but I do know that people like videos. So, when you have a colonoscopy done, we give you this prep because we want to clean it out and make it look all nice and pretty. And so we're going in very slowly and we're looking for these polyps. When you have a colonoscopy, everybody is really upset about drinking the prep. But if you don't take the prep as prescribed, we can't always see. And people think that they can eat grits and tuna in the morning and then come in and say, oh, I had a really light breakfast. You can't lie to us. We'll see it. It'll still be there. So it's so important to kind of follow the instructions, stick to the liquid diet the day before, drink your prep as prescribed, so that when we do this thing, we can be confident that this is a clean colon and you don't have to repeat it for another 7 to 10 years. So talked about the prep. I mean, back in the day, some of you who had a colonoscopy done by some barbaric person, they would have given you magnesium citrate. Only when I don't like people, I use magnesium citrate. So if your doctor gives you mag citrate, they do not like you, I'm telling you. So Miralax is kinder and gentler. You may have used this for constipation. We can dump this in some Gatorade, and this cleans you out pretty good. We have the Colite, which people don't seem to like because of the volume. It's 4 liters or a gallon, but this really does the job. And we're not giving it to people anymore all at once. You get to split it up and do half in the evening and then half very, very late at night. And this really gives the best results. We now even have a low volume kind of Colite. It's called Half Lightly. It's pretty expensive, so we don't have it readily available in the Bahamas, but it's proving that, you don't have to drink a whole gallon to get the same effect. This is what we don't want to see when we go in there. It's narrow, it's this obstruction, there's this blockage. These are people who have definite colon cancer. We're going to require surgery and probably chemotherapy thereafter. So what do we do to prevent colon cancer? Healthy lifestyle. Nobody wants to hear that. You know what I mean? Like, people ain't into that anymore, in general. But it's very important. This is what's killing us right here, right? Some of you had this for lunch today. And some of you are gonna have this for dinner. And this is basically what Bahamians eat on a regular basis. On the left, you see there's some green there, but that's only for presentation. People don't really eat that stuff. So it's just because they don't want the plate to look one color, you stick a little bit of foliage in there, and now you have green. But our diets are typically very, very low in fiber, high in fat, high in starch. And this is the diet that is at most responsible for colon cancer, the low fiber diet. And this is what we eat every day, twice a day, 365 days a year. So some of the things, just the whole healthy lifestyle thing, that people don't really like to adhere to, but this is what reduces your risk of colon cancer. Exercise and eating healthy, high fiber diets, quitting smoking if you do, drinking in moderation, and losing weight. So the obesity epidemic, I think it has something to play in breast cancer, possibly prostate cancer, and definitely colon cancer. And so, the whole healthy lifestyle thing with the goal of reducing weight and moving things through the colon is how you can reduce your risk of getting colon cancer. And then knowing your family history is really important. If have somebody who's died and you're not completely sure and it's a first degree relative, you really want to try and find out, even if it's second degree, you really want to try and find out what that person died from, and if it was cancer, so that you can get appropriate screening. This is important for colon, as well as for breast, as well as for prostate. Family history is really important in reducing your risk. And then getting screened at the appropriate time, which is at 45 for people of African descent and 50 for everyone else. And that's me. Thank you very much for listening, and any questions, I'd be happy to take it.
Please feel free to unmute and ask your questions, or you can put it in the chat if you don't want to say it yourself.
Hey, Dr. Cooper, thank you for offering and doing the talk for us again this year. Well, not this again, but again. I could always call on you, and thank you very much for doing the talk and informing the public about colon cancer. Just a question about NHI. You said you're getting the hemoccult testing done, and you hope to get the FIT test done. Do you find that the primary care doctors are really asking and screening these patients properly? Because I think, as you mentioned, the rate of colon cancer is growing, and we're going to be in the top 10 for that as well. Still, we don't watch out.
So yeah, I mean, colon cancer screening, I think, because of our efforts in educating the public, we're doing a much better job. When I came home in 2009, I don't think anybody really knew about Colon Cancer Awareness Month. And there were a lot of primary care physicians who were not routinely sending their patients for colonoscopies at all. And a lot of them weren't even aware that it was necessary. So we have education and repetition and reinforcement has definitely caused us to increase our screening rates. We get quite a few, lots of referrals from the clinics for people who are getting these cards done and bringing them in. Right now it's not ideal because you have to do 3 cards and you have these dietary restrictions, and it's kind of cumbersome. I do believe that the FIT test will get more of an uptake. And with the appropriate education, and because NHI will be covering the cost of the test, I do think we will do an even better job, but we're doing a pretty decent job now. But we can always do better.
Somebody has a question in the chat. How is our lynch prevalence in the Bahamas?
So we don't see a lot. Lynch syndrome is a syndrome that's associated with hereditary colon cancer. We don't see a lot of Lynch. There are some gynae cancers, I think, that are also associated with Lynch. We don't see that often. We do have the hereditary colon cancers that we see are usually associated with something called familial adenomatous polyposis. So these are families who have thousands, hundreds or well, not thousands, hundreds of polyps, or at least tens of polyps in their colon. It starts as early as in their adolescent years. And these people will almost invariably go on to develop cancer. So we do have some families that we've identified here. Dr. Monroe had been keeping a registry of these patients. And the recommendation is that you remove the entire colon, usually just, in very early adulthood or as a teenager. So we see more of the FAP hereditary colon cancer as opposed to Lynch or HNPCC, which is another type of hereditary cancer of the colon.
Can I ask you another question about NHI's strategies? Have you, well, I'm not sure if you're involved with it, but you must be, educating the younger folk. Like we know in the Cancer Society, we try to get into schools with our whole team and trying to promote healthy lifestyles and eating. I think we should get more education of the school children and the young adults so they can get good habits in terms of eating habits and exercise and all the good things. So that I think that needs some improvement as well.
I agree.
Has NHI earmarked any monies for that?
Yeah, so a part of what we're going to be doing, so cancer screening is what we're working on now. So we're expanding our coverage to include cancer screening. And right now we're focusing on breast, colon, prostate, and cervical cancer. And yes, there is going to be a campaign, an educational campaign associated with this rollout, where we're going to be not only educating the physicians, but the public as well. I do agree with you that we need to get into the schools about healthy lifestyles. So healthy eating, we had discussed having sugary drinks tax because, we eat unhealthy, the kids are obese and overweight. It's ridiculous. It really is. And you kind of walk around and you see what people are eating, and it's phenomenal. I mean, like I always say this, at least the last couple of times I've spoken, sometime between when I left the Bahamas to go and train and I came back, rice became a breakfast food. And I don't know exactly when that happened. When I left home, it was like grits and stuff like that. And then I came back and I went into one of these places and it was rice. It was white rice for breakfast.
Hey, China runs on rice,
Yeah, well,
we eat rice 3 times a day sometimes.
Yeah, but the Chinese don't have the same kind of body habits that we do.
We eat white rice, eh? We don't eat peas and rice, eh?
Yeah, but I mean, but white rice, and I guess it's because maybe our Chinese influence has caused us to eat rice for breakfast. I'm not sure, but
we eat rice porridge for breakfast.
Yeah.
Yeah.
So then we should blame you.
No, I have my
He's not obese.
I know, right? So it's people like Willie who are eating rice for breakfast 3 times a day.
It's the amount you eat, In Bahamas like to cover the plate. That's what the plate cover the plate. You must leave some
quantity.
It's true. So I mean, the things that we eat are literally killing us. And if you don't, if you don't try to find a way to educate people, not only educate, but you got to make healthy foods accessible. You can't just educate people and tell them, okay, eat good food, and then it's so expensive to do so. And you have fast food restaurants that are so cheap, and there's one on every corner. It just doesn't bode well. So education is a key component. I agree, and the government needs to find, if we're going to be serious about about the healthcare of our country and reducing our cancer rates and our hypertension and diabetes and obesity rates, I mean, you got to do some drastic things, and education is going to be.
Well, you know, Barbados just agreed to put a tax on the sweetened drinks. We mentioned that to the minister a couple of days ago, and let's see what happens. We're gonna push it as well, but you know, no one likes taxation, but it's probably what we need.
Yeah, we definitely need it. I don't know if we have the political fortitude to do drastic things like that, but you know, keep advocating. It's important.
Yeah, we gotta do.
So that's it. Thank you very much, and have a good night.
Thanks
Yes,
again.
thank you,
Cooper.
Dr. Cooper. Yes, thank you very much. We appreciate your presentation. Somebody else said very simple and informative. It certainly was. Yeah, and we would certainly like to see you back another time. Okay, so before we close out, I would just like to ask if we have anyone celebrating birthdays today or this week. This is Holy Week after all. Anyone celebrating either birthday or an anniversary, survivors' anniversaries, anything we'd like to share? Feel free to unmute and share. No? Okay. Well, then I guess we'll bring this meeting to a close. And I see the next scheduled date of our next meeting will be May 10th, same time, 6:30. So we look forward to seeing you all again next month. And that will be Cancer Awareness Month. And stay tuned, keep checking our website, checking your incoming email. We'll be keeping up to date on what promotions and what things we'll be doing in the month of May to spread the word on cancer and awareness. And like Dr. Cooper was telling us about, trying to do some early detection and screening, trying to keep people aware of the importance of trying to get ahead of the game. So before we close, I'd just like to wish you all a happy Easter season, and see you next month. Thank you for tuning in, taking the time. It was a
Good night.
pleasure to have you. Good night.
No problem.